The session on urban infrastructure examined built urban forms and how they were created, mobilized, and/or modified in response to epidemics. As we saw through this infrastructure, though this infrastructure was material and in many cases designed with permanence in mind, inhabitants moved to and through these structures, resisted them, and at times adapted them to suit their needs. In this way, infrastructure was and is as permeable as it is permanent, as symbolic as it is material, and each of these ideas take on particular significance and urgency during a time of pestilence. Our discussant today is Monica Schoch-Spana. Dr. Schoch-Spana is a medical anthropologist, a senior scholar with the Johns Hopkins Center for Health and Security, and a senior scientist in the Department of Environmental Health and Engineering at the Johns Hopkins University Bloomberg School of Public Health. She received her PhD in cultural anthropology from Johns Hopkins University and a BA from Bryn Mawr College. Her area of expertise includes community resilience to disaster, public health engagement and policymaking, crisis and risk communication, and public health emergency preparedness. Since 1998, Dr. Schoch-Spana has briefed federal, state, and local officials, as well as medical, public health, and public safety professionals on critical issues on health security. National advisory roles include currently serving on the Homeland Security Subcommittee of the Board of Scientific Counselors for the U.S. Environmental Protection Agency, the Resilient America Roundtable of the National Academies of Sciences, Engineering, and Medicine, and the NASEM Standing Committee on Medical and Public Health Research during large-scale emergency events. Dr. Schoch-Spana has led research, education, and advocacy efforts to encourage authorities to enlist the public's contributions in epidemic and disaster management. Her studies have been influential in reframing the management of catastrophic health events to include social and ethical moral dimensions, and persuading leaders to share governance dilemmas with the public, including how to allocate scarce medical resources in a disaster. She has chaired national working groups to produce peer-reviewed, evidence-based consensus guidance for authorities on how to partner with citizens and civil society in relation to bioterrorism response, influenza pandemic planning, and nuclear incident preparedness.
Great. Well, thank you to Caitlin and to Mohammed for this opportunity to respond and engage with the wonderful presentations for the urban infrastructure panel. It really is wonderful to be exposed to the history and the continuous ways in which outbreaks shape our social, economic, and political existence, and our interaction with the built environment around us. I very much enjoyed learning about Lisbon's Hospital Real in the 1490s, also Madrid's walls and city gates in 1600, the Lazaretto in Marseille, and then also, of course, Bombay, a port city that was whose residents, particularly those in the most vulnerable social positions, faced quite an impact from plague. What was striking to me was the fact that people, for the longest of times, will take extreme measures to manage the problem of, in the case of these 4 papers, of plague, of contagion. They build and administer walls and gates. They cite spectacular hospital structures on major sewage canals, and really shape and form their environment to deal with the threat of contagion. So we're looking at built infrastructures and forms of governance and social norms, and it's just amazing to me that the communities that we build around us are so affected by contagion. I did want to engage some of the themes that came up in the papers or presentations to what's happening today with the COVID-19 pandemic. And that extreme investment of a community's resources in managing the presence of contagion sticks in my mind. Today, we have what is a very strong desire to get back to a so-called normal, to leave the presence of contagion, to resume apparently a peaceful existence, not interrupted by the looming threat of contagion. So I imagine when I was hearing these panelists speak that in those communities, in those centuries, there too was a strong desire, like we're feeling today, to somehow be sprung free of a moment in which contagion is dictating our social rhythms and our economic exchanges and our literal physical existence out in the world. But there were two things that I wanted to follow up with that on the theme of the desire for so-called normalcy or a return to the way things were. And there were several aspects I wanted to touch on. And that is, I think with regard to COVID-19, we're still caught up in a response mindset, right? We're trying to manage the threat of COVID-19 in our presence. We are trying to, in all of our communities, tackle the question of how, when, and if we will continue to keep open our businesses, schools, our recreation facilities, and places of worship. People want to reopen for normal operations, and political leaders have been grappling at local, state, and federal levels as to what is the best decision that would allow us to adapt to this protracted pandemic and its cascading social and economic effects. So this question of reopening is often seen as a return to the normal, right? Let's try and resume our routines. But if we step back and resist that urge to return to the normal, we can look at a time of contagion, as painful as it is, as a moment in which we can think about a process of overall community revitalization. So we need to sort of step out of a response mindset and think more in terms of a longer term process of post-COVID-19 recovery over the near, intermediate, and long terms. So while everyone wants to reopen and return to normal, we need to resist that feeling, which is very common in a disaster context. So it's certainly prudent right now for our political leaders to be proactive and plan for the future well-being of their residents, not just for the immediate concerns of when can our everyday institutions reopen. So we need to attend to those deficiencies that have been communicated to us as this epidemic has unfolded. We've seen deficiencies in healthcare delivery, social safety net, and our workplace leave policies. And so we have this immense opportunity to deal with other forms of urban infrastructure, which are those infrastructures such as our mental health infrastructure, our public health infrastructure, our health and human service delivery infrastructures. All of those types of infrastructures on which we rely on a daily basis, not just our built environment, are things that require revitalization, investment, and rejuvenation. And so I know we've focused, the focus of the panels were on these tangible infrastructures, also symbolic at the same time. It's these service-oriented infrastructures that I think we also need to pay significant attention to. And the type of revitalized or transformative recovery that is possible in the COVID-19 case means that we need to, while we're still in a state of public health response, also start a larger process of thinking about what type of community and society we want to have as we learn along the way how best to respond to something like a pandemic, but how, even more importantly, to deal with deficiencies that exist in our various systems. And questions of reopening should very quickly be, or are just the start of a larger conversation that buen gobierno, as one of our panelists said, good government should be having with stakeholders and the public at large, is what is it that we want to do in terms of transformation as a result of the pandemic. So that transformative recovery is something that I'd like us to think more about. And as I mentioned earlier, it's these other forms of infrastructure that need careful tending. The mental health infrastructure in the United States is very weak. We have a lack of parity between physical health and emotional health in terms of how our insurance systems work, how we culturally value different types of care. We still have a problem with stigmatization of individuals who seek out mental health care. We have a very limited number of mental health professionals in the United States, and we need to grow that workforce. We also need to assure its affordability and accessibility for people who need mental health care. Right now, Americans have a hard time, at least in the United States case, have a hard time plugging into the mental health infrastructure. They simply don't know where to go, how to plug into, can't afford it, or afraid to be associated with it. So that's another kind of infrastructure that we can reform and rebuild, knowing that there have been extreme demands being placed, extreme stresses being placed on our communities. So much in the same way that the monarchy, who was concerned about the quality of air in Lisbon, invested in a hospital sited in an appropriate place, we need to think about what investments we are making in infrastructures, such as our mental health infrastructure here in this case in the United States, from where I'm sitting. The same is true for our public health infrastructure. Again, the personnel, the protocols, and the public trust that are needed so that we can hopefully mitigate the impacts of future outbreaks of infectious diseases. If you look at trends over the last few decades, we're only going to see more outbreaks that are hard to manage based on the trends that have been monitored by the World Health Organization. So much in the same way as we're looking at the possibility, given a changing climate, for the presence of more frequent and more serious meteorological events like hurricanes. We're also looking at the possibility of increasing numbers of outbreaks of infectious disease that are going to be harder to manage. and we need a public health infrastructure um, in which the public trusts in order to manage that type of concern. So I do want to conclude with a focus on, or to reiterate that we need to step back while recognizing this impulse to return to normal, and ask ourselves, why return to normal when we can actually take reforms that are going to bring us to a better quality of life if we tend to the root causes of the health impacts of this particular outbreak? Why don't we have a transformative recovery as opposed to a return to normal? And secondly, that there are infrastructures on which human well-being depend that we have to invest in further. And those include, in the United States case, our mental health infrastructure and our public health infrastructure. So I want to thank the organizers for the opportunity to engage with these spectacular historical cases of the extreme measures and the high impact investments that communities made in order to manage contagion, and challenge ourselves to also take high impact steps to transform our communities and improve these human well-being infrastructures on which we depend on a regular basis. So thank you, Mohammed and Caitlin, and to the panelists. And I wish everyone well in these days of pandemic.